Great. So we are able to start now. Thank you so much, everyone, for joining us today. We're having another digital Infoday session on MGUS and overview. My name is Alice. I'm the Head of Patient and Carer Information and Support at Myeloma UK. So firstly, I'd like to let everyone know that this session is being recorded and will be available to watch on our Facebook page and our website soon after. So if you have to rush off or if you miss any bits or want to rewatch, you can find it there. Before we hear from our speaker, some of you may not be that familiar with our organisation, so I'd like to tell you briefly who we are and what we do. Myeloma UK exists to support all those affected by myeloma and its related conditions, of which one is MGUS. And we also support those affected by smouldering myeloma and AL amyloidosis. We are patient-focused and we aim to empower, inform and support patients in everything that we do. As an organisation, we rely on the generosity and kindness of supporters who fundraise and donate. Myeloma UK receives no core government funding, so your support is vital. We're truly thankful for all contributions as they allow us to continue working to help patients, their families and their friends and put on events like this. Throughout this evening, we'll be popping website links, publications and useful information into the chat box. If you have any questions that you would like our expert to answer, please use the Q&A box at the bottom, or it might be at the top of your screen, and we will try to answer as many as we can throughout the webinar. In this session, you will hear about how MGUS is diagnosed and managed, as well as ways you can access support. We will also provide tips on how to live well and deal with the uncertainty of this condition. We do get quite a lot of queries about MGUS in our info line and Ask Nurse email service, so I hope we'll be able to provide some information and support to you all this evening. Now, I'd like to welcome this evening's expert, Dr. Simon Stern, a consultant haematologist at Epsom and St Helier University Hospitals NHS Trust. Welcome, Simon, and thank you so much for joining us, and it's really nice to have you presenting this webinar for us. So now let's get on with things, and I'll hand you over to Simon to start with the presentation.
Thank you, Alice, and I'd like to thank all the team from Myeloma UK for inviting me to talk about this subject tonight, and thanks to everyone, who's given up as part of their early evening to listen. So I'm talking about, as I said, the monoclonal gammopathy of undetermined significance. That's the only time I'm ever going to read it out in full. There are a few sort of niche people who refer to it as MGUS instead of MGUS, but there's only one U in MGUS, so it's going to be MGUS from now on. So what am I going to talk about today? It's exactly what MGUS is, for those of you who don't know or might only have a scanty knowledge, how we manage it and how we follow patients up who have the condition, and very importantly, some information about how to live well with MGUS, because it is a sort of Damocles-like diagnosis for some patients, and I hope by the end of this, you'll be reassured that you can live a happy, normal life while still having MGUS. So we need some three, I think, take-home messages from the talk. The first one is that MGUS, this is difficult terminology, but I described it as a pre-malignant condition. We can go into a bit more about that later on, and even in the Q&A if you like. The majority of patients, it won't progress or require treatment, the vast majority of patients. But nevertheless, once you've had the diagnosis, it is important for you to be vigilant for any possible symptoms that you might develop that might suggest it's transforming into something more serious, and the importance of telling your healthcare team if that occurs. And finally, we really do want this to be a message of reassurance. We don't want you to become over anxious about it, but still to ask for support when you need it from Myeloma UK and your healthcare professionals. So to start with first principles, I suppose, you can't have MGUS without a paraprotein. What is a paraprotein? Well, in terms of its structure, it's very much like the antibodies that we hear so much about now following things like COVID vaccinations. It's exactly from that class. And we all make antibodies against infections and other foreign antigens in the body, and that's very important for fighting infection. However, the paraprotein that we see in MGUS doesn't actually have any functional use. It's got the same structure, but it's just there, protein drifting around in the bloodstream, and can obviously be measured when we do the necessary blood tests. The cells that make the paraprotein, just like cells that make antibodies, are found in the bone marrow. So, just to go into a little bit more detail in terms of the structure, all paraproteins that are intact are called, as seen on the structures given on the right there. They all have a heavy chain, or 2 heavy chains, and 2 light chains. There are 5 different sorts of heavy chains. They're listed on the slide. The common ones are G, A, and M, and there are 2 sorts of light chains, kappa and lambda. And you can probably see there's a large variety of combinations that you can have. So you can have an IgG kappa paraprotein, you can have an IgG lambda, IgM, kappa, etc., etc. But they all essentially have that same structure that's illustrated on the right there. So, if you see on your clinic letters, or when a doctor talks to you, or a nurse specialist talks to you, they'll talk about what sort of MGUS you've got. And so we take the name from the heavy chain. So you have an IgM MGUS, an IgA, or an IgG, for example. Sometimes they're classified in different ways, like non-IgM, but I think it's probably easiest just to call it what it is. Name it after the exact structure of the paraprotein. There is a variant. Remember on that previous slide, the light chains? You can have an MGUS where the cells that produce the protein just produce lots of the light chains without the heavy chains attached. And in that way, you can have what's called light chain MGUS, and that will either be kappa or lambda, because they're the 2 sorts of light chains. I think because it's not a diagnosis that's talked about much in the national news or the papers or television, people, when they're given the diagnosis, are often surprised to realize how common it is. This to say, there are a lot of people walking around who have these paraproteins. Some of them know about it, others don't know about it. But if you do population testing and you look at certain age groups, in the over 50s, 1 in 30 of people over 50 will have a paraprotein or MGUS. And the older you get, the more likely you are to have one. So in the ages of 70 or older, 1 in 20, that's 5% of the over 70s have got MGUS. And in the over 85s, it's 10%. So this is a very common condition. As you saw from the previous slide, age plays a factor in determining how likely you are to have MGUS, but there are other factors as well that are important. We tend to see MGUS more commonly in men than women. We tend to see it more in people from Black ethnic minority groups, and probably less in the sort of South Asian population. And family history. There may be some questions about genetics later on. There's no clear genetic inheritance in as much as you don't often see, or very, very rarely see, parents passing it on to children. But we do know it's more common. If you've got a close relative with MGUS or myeloma, you are probably statistically more likely to have MGUS yourself. So I think of all the features of MGUS, what's the most important thing to remember about it is does not cause symptoms in the vast majority of cases. We're going to talk about, there's always exceptions to prove rules, and we'll talk about those in a minute or two. But it's a key diagnostic feature of MGUS that this paraprotein whizzing around your body in the blood doesn't actually cause symptoms. And as a result, it's often picked up by chance. So, for example, a patient comes in to have blood tests before an operation, and we do liver function tests. And that might show that the temporal protein in the blood is rather high. And so we investigate that further by doing special tests to look for paraprotein, and we find it. So that's a chance finding. Sometimes when patients come in just unwell, doctors, being what they are, like to test for a multitude of things with in one hit. So although we might not have any suspicion that the patient has a paraprotein, we might test for them. For example, if they were unexpectedly anemic. So, no, we can pick it up during those sort of blood tests as well. But, these are the minority of people, as implied in the previous slide with where I was showing the numbers in the over 70s, for example. Most people will not actually know that they've got the condition. They're walking around in blissful ignorance. So there are some very important tests that some of you may be familiar with. But the good news is, in the vast majority of cases, we just use blood tests. We do nothing more invasive than that. So what will we see? We'll see a paraprotein in the blood, less than 30 grams per litre. If it's more than 30 grams per litre, we're then talking multiple myeloma, but we can talk about that again in the questions later if you like. There'll be very little or probably no protein in the urine. The patient will have a normal blood calcium level, normal kidney function, and usually won't be anemic, to be fair. So the vast majority of tests that we do in an MGUS patient are in fact normal, but the glaring exception to that is the presence of the paraprotein. If we think someone might be on the borderline between MGUS and multiple myeloma, we may well go on to do other investigations. The classic one is a bone marrow biopsy to see if there's an excess of the number of the so-called plasma cells that produce the paraprotein in the bone marrow. We may also do special X-rays or scans to see if there's any bone damage. But what the key thing in MGUS is, if we go on and do those tests, the bone marrow will show less than 10% abnormal plasma cells in the bone marrow, and the scan will not show any bone damage. So that puts patients definitely in the MGUS category. So what do we do when we diagnose it? It's quite often now that GPs are more sensitive to picking these up than they used to be, and that they'll send a patient in for an assessment, and we diagnose MGUS. So what is the next step? Well, patients are often relieved to know they don't, certainly in the beginning, that they don't need any treatment. So we're going to do what's called active monitoring or watch and wait. So that means seeing the patient periodically, or even having a telephone conversation periodically, maybe for the first 6 months, every 3 or 6 months, then maybe even annually after that. We don't just do blood tests. We feel it's important to talk to the patient as well. Any new symptoms that they might have developed, and we can discuss those over the phone. And who does the monitoring? Well, MGUS can be monitored in a variety of places. They can be essentially in hospital or in primary care. My view is that the patients with a higher risk of transforming to myeloma should probably be managed in hospital, and those with a lower risk should be managed in primary care. But it's not once that die has been cast and you go down a certain pathway, doesn't mean that you can't go back the other way. So, for example, a patient by being managed in primary care might develop symptoms of concern, or their paraprotein might be rising. In that case, the GP would refer the patient back to the hospital. The tests we use, again, fairly routine now, and fortunately, just blood tests, nothing more invasive. So every, say, 6 months or once a year, or however often you're being monitored, we will check the level of paraprotein in your blood. If it's a light chain MGUS, we would check the level of light chains. We would check your blood count to make sure you're not becoming anemic and that you've got normal numbers of white blood cells and platelets. And I think very important, we test the kidney function as well. And a little advert for something that we've done in Myeloma UK, which is to make a patient diary. And a lot of patients like this. That means that they can log the results every few months when they have the test. They themselves can follow the results, see if they're stable or see if they're heading in one or other direction. And the really IT whizzes then turn those into spreadsheets and graphs, and they like bringing them to the clinic. But so that these patient diaries at Myeloma UK, I know have been very popular with quite a number of patients. So I talked about the exceptions that prove the rule. A couple of related conditions. Well, I call them related. They are still MGUS, but they've got different acronyms, as you can see, MGCS and MGRS. So MGCS, monoclonal gammopathy of clinical significance, monoclonal gammopathy of renal significance. What are these conditions? Well, the bottom line is they've got MGUS, but in these rare patients, the paraprotein actually does start to cause some damage to the body. And paraprotein, or the light chains, can perhaps damage the kidneys, damage the skin and cause a rash, damage some of the peripheral nerves and cause a neuropathy. And just to stress, these patients haven't got multiple myeloma. So if you do a bone marrow, they've still got less than 10% plasma cells. They've still got no bone damage, but they've got MGUS with the paraprotein actually affecting organs. And these patients may require treatment. Just to give an example of monoclonal gammopathy of renal significance, the most common one, or the most one you're most likely to have heard of, is something called amyloid or amyloidosis. And that can affect the kidneys. Again, happy to answer questions along those lines. And talking of questions, I think we're going to pause there. Yes, we are. And I think Alice may have some questions for me.
Yes, I do. Thank you for that, Simon. It was a really interesting start to this evening. So this is our first Q&A session of today's event. We do have a second one coming up. And thank you to everyone who's already submitted questions. And if you've got any more, please do pop them in the Q&A box and we'll do our best to get to them. So let's start off with the first question from Sarah Jane. And this is something that you touched on earlier, Simon, but one of her hematologists calls MGUS precancerous and another calls it cancerous. What is the correct definition? I believe we called it pre-malignant earlier.
Yes. It's a difficult one. There's a certain degree of semantics here. I think when a doctor or a specialist is calling it cancerous, what he or she's referring to is the fact that the plasma cells that produce the paraprotein are all of the same clone of cells. That's why all the paraprotein is of the same type. So IgM, kappa, for example. So if you're one of those doctors or scientists who feel that if you've got a single clone of cells, that is a cancer, then I can see why that description is given. I prefer to think of cancers in which the growth of the cells or the division of the cells is uncontrolled. And I don't think that's really the case in MGUS. These plasma cells are less than 10%, remember, they're sitting in the bone marrow, producing the protein. We know there is the risk that these cells could become more overtly malignant, perhaps lose the same, not have the same control that I was talking about earlier. And that's why I prefer to call it pre-malignant. But it's a slightly controversial issue. I think you can get a bit too hung up on it. I think the key thing to remember is MGUS is a condition that needs long-term monitoring.
And then by clone, do you mind just clarifying that for us?
Yeah. So clone, that means they've all got the same genetic structure, not just that they look the same under a microscope, but if you look at the DNA level, they're all exactly the same. So they're for the sake, they'll all have originated from one cell, and that cell is divided and produced identical cells that are all producing the same paraprotein.
Oh, thank you for clarifying that. And that leads to another question, actually, which is some people may know about myeloma and smouldering myeloma in particular. What's the difference there between MGUS and smouldering?
So smouldering myeloma there are similarities and differences. The main similarity is that patients with smouldering myeloma do not have symptoms. So again, they tend to be treated by monitoring alone, watch and wait. However, if you do a bone marrow in a patient with smouldering myeloma, they will have more than 10% plasma cells. So that puts you over into the myeloma category. Smouldering myeloma, patients do not have bone damage. So that's where it's similar to MGUS, but they just go over the threshold by having more than 10% plasma cells, or by having a paraprotein level that's very high, more than 30 grams per litre. So in many ways, they're very similar. They often behave very similarly, carry on relatively stable, but there is a key diagnostic difference.
No, thank you. And talking of symptoms, you mentioned MGCS and MGRS. Could you explain a little bit more about that? Particularly, peripheral neuropathy has been brought up by Sarah in the question.
Yeah, peripheral neuropathy. Yes, peripheral neuropathy can be quite debilitating and unpleasant. What happens is that the peripheral nerves the nerves that, for example, going into your fingertips or your toes, get damaged directly damaged by the paraprotein, which acts as a sort of antibody attacking the nerves. And that means the nerves work less well, and because the nerves are damaged, that results in symptoms. So that could be pins and needles, numbness. It might even be pain, which is quite unpleasant. So it says that would be a classic example of MGCS. So MGUS with the paraprotein causing damage to the nerves.
Yeah, thank you. And is fatigue something that's part of MGUS?
Not classically. I think I've mentioned a couple of times that the patients are not anemic, whereas in myeloma, patients are often anemic and experience quite a lot of fatigue. I try and, much as I can think is possible, I think of MGUS as a non-symptomatic condition, and it'd be rare for the paraprotein itself to cause fatigue.
Okay, thank you for that. So we've got a question here a bit more about the genetics of MGUS. Could you tell us a bit more? You said it's not passed from parent to child, but is there a genetic link, and can that be tested for at all?
I think there's a lot of research going into it, but there are no tests at the moment in widespread use. But there's no doubt that families in whom it's more prevalent are going to be studied more and more in the future, because it's useful information. So when we think of genetic disease, we think of diseases where there's a clear genetic inheritance, something like haemophilia, for example, or cystic fibrosis, where you can draw up a family tree and you can see how parents or pass the condition on to children. MGUS isn't like that, but there must be some sort of genetic predisposition in families, still to be formally discovered, but an important area of research.
Yeah, absolutely. I think we've probably got a little bit more on that later on, which hopefully will answer a bit more on that question. Yeah. We've had a question from William, so thank you, William. And this is about the monitoring process that he's going through. So he said, initially for the first 2 years, I had blood tests every 3 months. I then moved to testing every 6 months, and currently he's tested annually. Is this an adequate testing regime, or should I be monitored more closely?
Well, without knowing William's blood test results, I wouldn't like to go too much on that, but it sounds like good news to me. It sounds like the team were very conscientious when they started, and I would guess that his results have been pretty stable. And now, once we're sure that someone's being stable over a long period of time, we do gradually extend the intervals between appointments. And we feel we can do that quite safely with patients who are aware of what the signs are to look out for were there to be progression. I mean, we do know, and we don't quite know why this is, that patients with MGUS who do progress to myeloma tend to do that relatively early in the follow-up period. So if a stable patient has been stable for 2 or 3 years, we are quite happy just to go for once a year formal monitoring.
And would you say once a year is the minimum?
That's the minimum, yeah. I think if you go longer than that, you just become sort of, as I say in medical jargon, lost to follow-up. Doctors lose track of you, nurses lose track of you, patients forget. So I think having an annual as a minimum is the right thing.
Mm-hmm. And is that something that patients should be asking their GP or whoever's monitoring them?
Yes, and I think things like these diaries are very good in that way. And we know how busy GP, for the patients who are being monitored in primary care, we know how busy GPs are. And it's easy to see how they can get distracted by patients who are more acutely unwell. So what I like about the diary is it gives patients sort of ownership of the condition. They can see when their last test was. If they haven't had a reminder within a couple of weeks of when their test is due, they can be proactive and contact the surgery and say, "Oh, I'm due my test," and that's a good way to make sure you don't fall through the net.
Yeah. Oh, that's excellent. Thank you. So we've got another question from Clive, and they're asking whether it's possible MGUS might be misdiagnosed as another condition, such as chronic fatigue or ME. And there's another question from Jane, similar, of can light chain ratio that's imbalanced be caused by any other condition?
So we'll start with the first question, the ME chronic fatigue. I think it's the other way around. I don't think anyone with MGUS will be told by mistake they've got ME or chronic fatigue syndrome, for the simple reason that MGUS is a non-symptomatic condition. On the other hand, it's quite possible to have both. It'd be quite possible to have chronic fatigue syndrome and MGUS at the same time. So I'd look at it that way around, to be honest. Just remind me what the second question was, Alice.
So that was about an imbalance of light chain.
Yes. So we do see raised light chains in other conditions, for example, in kidney failure or renal impairment, and we sometimes see it in patients with chronic inflammation. However, what you tend to see there is both the kappa and the lambda light chains coming up together. The thing about MGUS is there's a big disparity between the two. So the kappa will be up there, lambda will be down there, normal or maybe even low. So those are the ones that sort of raised a red flag to me. If a patient has got high kappa and lambda, I don't think they're going to have MGUS.
What would you say that it possibly could be in that situation?
Well, as I say, even after a recent infection, you can have both the kappa and that. Because remember, these antibodies and paraproteins are the same sort of structure. So if you've recently been churning out a lot of antibodies and those antibodies get broken down, that's going to release light chains into the blood. So you can have kappa and lambda light chains. And also, we do see that with that pattern in kidney failure, kidney impairment as well.
Okay, thank you. So this is the final question in this Q&A section, and that's from James. And it's about COVID and what is the latest information on how well the COVID vaccine works in MGUS patients? And do MGUS patients still need to take extra precautions?
That is a good topical question. Well, when COVID hit, it really took us all by surprise, and we had to act very quickly. So certainly in our unit, we took the view that MGUS patients might be more at risk of COVID infection. And so we did treat them as the clinically vulnerable group. And we did advise, expediting their vaccinations. However, there's recent work, there's a study in Iceland that I'm going to talk about in the second half of the talk that has looking at lots and lots of MGUS patients, and they studied them during COVID. And it appeared to them that MGUS patients, unlike myeloma patients, weren't particularly susceptible to COVID, which I think is very good news, actually, in terms of encouraging patients with MGUS not to be too restrictive on their activities.
Yeah, absolutely. That is fantastic news for MGUS patients, definitely. Great. So I'll now let you carry on with the second part. Again, if you've got any more questions, please do feel free to pop them in the Q&A box, and then I'll come back to Simon to carry on.
Okay. So we've touched on this a little bit already, but why does MGUS need monitoring when the vast majority of people with MGUS will have a stable condition that does not impact on their life? Well, it's this risk of transformation to other conditions. So let's stress that it's a small proportion, but MGUS can progress to multiple myeloma or smoldering myeloma, as we talked about. And the risk overall in MGUS is 1 in 100 per year, so 1% per year of transformation. Other conditions, AL amyloidosis, well, we talked about that as a potential form of MGRS, but amyloidosis can affect the whole body, and that would be a way that MGUS could progress. And sister condition to myeloma, non-Hodgkin lymphoma, or sometimes given its long name, Waldenstrom's macroglobulinemia. These are patients with IgM MGUS. So IgM MGUS tends to progress more towards lymphoma, whereas all the others, IgA, IgG, etc., tend to progress, if they're going to progress, to multiple myeloma. So what we want to do, and the reason for monitoring, is to pick up these transformations at an early stage rather than late when the patient may have more symptoms. Predicting who's going to do that is difficult. When any new MGUS patients, it's difficult. However, we can do a form of what we call risk stratification. We can give a patient a diagnosis, an idea of whether they're going to be low risk or higher risk. And that's really due to just the simple blood tests that we do at diagnosis. Now, remember that risk of progressing is still very small for all patients, 1% per year. But however, it might be a bit more if, for example, you had all those three characteristics in the bullet points on the right. So an abnormal serum free light chain ratio. That means, again, this discrepancy between kappa and lambda. We think the risk's a bit higher if your MGUS is not IgG. So if it was IgA or IgM, for example. And we also think the risks are higher if you've got a high level of paraprotein at the time of your diagnosis, notably if it's more than 15 grams per litre. So I was talking about where patients are followed. If, for example, we had a patient with, say, 2 out of 3 of those bullet points on the right, I think we'd want to follow them up in hospital, either in a standard hematology clinic or in a nurse specialist clinic. And that way we can be sure that we've sort of segregated out the high-risk patients and that perhaps have a slightly closer monitoring than the lower-risk patients. Right. So what patients with MGUS want to know is, how do they know if it's progressing? Well, the blood tests are the key, because remember, MGUS tends to not have symptoms. So all those blood tests that we do when at these routine follow-up appointments, paraprotein, the light chain levels, kidney function test, checking the calcium, remembering that the blood calcium can go high in myeloma, and anemia. So if we picked up what we might call significant progression in any of those, that's when we think, okay, let's investigate a bit further. Let's see if this has perhaps transformed to smoldering myeloma, for example. So the patient's still not got any symptoms, but they may have gone over the 10% mark in the bone marrow. So we'd be most likely to do a bone marrow biopsy, and we'd probably do some scans as well to see if there was any bone damage suggestive of myeloma. Symptoms can be difficult to because they're quite generalized and a bit vague. So a generalized reduction in well-being, I think, is a good thing to talk about. Maybe, we've talked about fatigue already. Significantly worsening fatigue over a period of time. Those two might be suggesting of transforming to a more serious condition such as myeloma. In addition, patients with myeloma are more prone to infection. So if you start developing more infections, needing more antibiotics, that might be a warning sign. New pain in the back or the ribs, certainly a new fracture that comes out of the blue. In terms of other symptoms, we think about swollen legs or the abdomen, and that might suggest you're retaining fluid, easy bruising, which didn't used to be present. To go back to the neuropathy, numbness or tingling in the feet, or that, in the legs or the hands, and breathlessness, which we do sometimes see in patients who are anemic. So that's a broad overview. I think the general message is, if you feel your health is deteriorating for whatever reason, get in touch with your healthcare team and suggest that you're worried about your MGUS progressing, and they should act. They really should act on that. I think MGUS it can be a difficult diagnosis to live with, because on the one hand you're being told, don't worry, it's fine, you don't need any treatment. Vast majority of you won't progress. But there is this degree of uncertainty, and we talk about watch and wait. I think a lot of patients have coined the phrase watch and worry or wait and worry. Because no matter what, no matter how sort of calm they may be on the surface, they are worried that this thing might be progressing. And I think patients often feel that in the run-up to their regular blood tests. But I think the positive way to look at it is that you are being monitored, and if you are being tested, that means we'll pick up the progression at an early stage. So I think it is important to stay as positive as you can. Live a normal life. It's perfectly okay to have some bad days when you're a bit more concerned about the condition, but do try and live as normal life as possible. And whatever helps you do that is all to the good. So if that's complementary therapies, if that's mindfulness, meditation, whatever, if it's helpful to you, absolutely the right thing to do to pursue it. So where can you look for support? Well, I like to think that the healthcare team, certainly the hospital teams, will be a good source. Clinical nurse specialists are often the best first point of contact for this. But there's also all the resources that Myeloma UK have to offer, like the info line, there's the Ask the Nurse email service, the discussion forums, and of course, family and friends. Potentially the best source of support at all. But you do need to decide who to tell and who you think would be helpful to bring in, and those that maybe you may not want to tell. And any form of talking therapies may also be beneficial. It doesn't have to be someone who is a specialist in hematology or MGUS or myeloma. Anyone who can provide support can only be a good thing. So, we don't want people to be obsessed with their symptoms, but don't be shy about reporting symptoms to any member of the team if you start getting those, for example, those symptoms that we discussed about on the previous slides. New pain, particularly new fatigue, a tendency to develop infections. But, we're all entitled to get aches and pains as we get older, and absolutely may not be the case that the MGUS is in any way related, that may not be that the symptoms are in any way related to MGUS or progression of MGUS. Alice very sensibly prompted me to say that, book it. If you're worried about getting missed, book your blood test in at an early date. If you're in primary care, and make sure that you register with a new GP if you move house, and you can request, previous clinic letters from your previous hospital to be forwarded, or if you've got copies yourself, you can forward those to your new GP. It's an exciting field. There's a lot of research going into MGUS. A lot of it is centered on the University of Birmingham. And we're looking at the cells that are responsible for MGUS, and looking at ways that potentially they can prevent slowing down the development of myeloma. That would be the gold medal here, wouldn't it? It would just be to hold, okay, you've got MGUS, but can we hold it in that holding pattern for really long periods of time? They've got a lot of IT specialists who can look at the qualities of patient data that can identify which MGUS patients are more at risk. So those could be monitored more intensively. This would be the basis of a national screening program if we ever get there. And I'll talk about that on the next slide. But I think the key to any research is identifying as an early stage as possible who's likely to progress and who isn't. Now, we screen for all sorts of conditions now, and including malignant conditions like carcinoma of the colon. We haven't got to the stage where we are at screening for MGUS because, there has to be an element of cost effectiveness here. But if we can make the case, then it really would be a good thing to be able to do. So what of course we want to do is identify patients early, and that's the basis of screening. So we spot them before they've developed myeloma, before they've developed the sort of tissue damage, organ damage that we see in myeloma. And very encouragingly, there's a large trial taking place currently in Iceland that will really give some useful information about that. They're looking at everybody in Iceland born before 1976, and they're giving the option of having having blood tests and identifying people with MGUS who had no idea they had MGUS. And then they're going to be randomized 3 different ways. A third of them aren't followed up at all. A third of them have the sort of standard follow-up that we've been talking about in the previous slides. And a third of them have much, really quite intensive follow-up and investigations. And that will be very interesting to see if this will, reduce the incidence of patients in Iceland presenting late with myeloma. It will also do look at some quality of life issues to see the psychological effects of being diagnosed and followed up when previously you had no idea that you had the condition. So I think that's important. It might be a downside to screening. And I take my hat off to them in Iceland. Now, to identify everyone before 1976, born before 1976, is quite an achievement. Of course, you should remember Iceland's a very small country, and it's often said to have a population about the size of Croydon, the last time I heard. So it's not that great an achievement, but it's great. It's very well organized, and I think it will produce some very useful results. So,
yeah, thank you so much for that, Simon. It was really interesting, and I hope it helps some people understand what they should be looking out for, in particular with symptoms. So we talked about telling your healthcare team about your symptoms and if you're experiencing any. At what point should you be telling them? Is it first time you pick up a cold? Is it second time you pick up a cold? What would you say?
No, I wouldn't say necessarily. I would say, are you become noticeably more prone to infection? Are you at your GPs having antibiotics for chest infections more than you used to? Similarly, we can all do some heavy lifting or work in the garden and have some pain in the back afterwards. What I'd be more concerned about is sort of back pain that comes out without any obvious exertion, and it's persistent. Doesn't sort of come and go, but it's just there nagging away all the time. Similar with fatigue, we can have busy days, we can have stressful days when we come home feeling very tired, but is it a sort of all-encompassing fatigue that you didn't used to have?
Yeah, thank you. And along with that, we look at the blood test results for possible progression. Is it just one-off results that might be very elevated or very decreased that you would do something about?
No, I think I like to see a trend rather than just go on a one-off result. So if, for example, someone with MGUS, their paraprotein went from 6 to 9, then I'd raise my eyebrows, but I don't think that is absolutely not diagnostic of a transformation to myeloma, because 3 months later, when we did it again, it might be back at 7. So I like to look at results over a prolonged period of time and not to get too excited about just a one-off individual result.
And we talked about the sort of time between being seen by a specialist or GP. Is it something that they might bring in a little bit more frequently, the monitoring, if they were worried?
Yes. So say a patient had been on annual monitoring and we saw that change in the paraprotein, I think we'd probably say, let's test you again in 3 months or 4 months rather than go another year. So I think, there's got to be some fact. I don't want people to get the impression that once you're on once a year follow-up, that's it. And, that's a preordained pathway you're going on. I think there's got to be a degree of flexibility.
Mm-hmm. Absolutely. And can patients ask to go and see their hematologist again, or would the GP likely to say no at that point?
Well, if they're in primary care follow-up and they've spoken to their GP and they've listed their concerns, I think it'd be very reasonable to ask to be referred back in, yes. Now, the GP may say, well, let's do some blood tests first. And if the blood tests are very much the same as 3 months earlier, whatever, then that may be enough to reassure the patient. I think I like to think of the symptoms being a trigger to perhaps bring blood tests forward rather than necessarily make an urgent referral. Now, if a patient suddenly had a fracture or something really quite serious like that, well, that's another matter. But I think just the first step, probably bring forward the screening blood test and then see what they show.
Yeah, thank you. Yeah, hopefully that's reassuring for people that they won't just immediately get referred back in. They will have good conversations with their GP about what's going on. Now, we talked a little bit about progression. Is there anything that's preventative to stop people progressing from MGUS onto something else?
Well, there is no doubt that if you gave patients the same sort of drugs that you give to patients with multiple myeloma, you would delay the progression. However, that is certainly, I would certainly say that's not the right thing to do. Because remember, only the vast minority of patients progress. And the other thing to remember is these drugs have got their own significant side effect profiles. So, I can imagine at some stage there might be a trial if we find a myeloma drug that's got very few side effects and patients are prepared to take it, then we may see the day when some MGUS or high-risk MGUS patients are given the drug. I don't think we're at that stage yet. There are no other, I wouldn't necessarily say there is anything else to be done, really, other than to perhaps just, live a normal, healthy lifestyle. No specific treatments that we know of can delay it. We're as sure as we can be that myeloma drugs would delay it, but no, absolutely, I don't think that's the right thing to be doing.
Mm-hmm. Yeah, I suppose it's the benefit of that and whether it's actually where most people are quite well.
Risk benefit, you'd be treating a lot of patients with strong drugs who don't need to be on those drugs.
Great. And linked to that, is there anything that we know of that can trigger MGUS becoming, say, active myeloma or another condition?
Well, nothing specific, although you get good or interesting, not just good, but anecdotal stories. For example, you may have read recently that they were looking at firefighters and rescue workers who'd been involved in 9/11, and they'd found a high rate of myeloma amongst them. Now, all patients with myeloma must have had MGUS once upon a time. So that makes you think, maybe something in the chemicals or whatever that was released at the time. People tend to think about toxins or chemicals that might cause genetic changes that might cause the progression from MGUS towards myeloma. But certainly in terms of lifestyle, there's no specific things to say, don't eat that, don't do that. That'll reduce your risk.
And we mentioned about particular types of MGUS and particular types of immunoglobulins being higher risk. Is there anything else between, similarly, like with other health conditions that might link in with MGUS and possibly cause it to progress faster?
Not so much. There are sort of disease associations, if I want to put it like that, but I don't think they necessarily make MGUS progress further. So in patients with MGUS, you're more likely to have patients who have venous thrombosis, for example, or maybe coronary artery disease. Now, it's not a cause and effect. It doesn't mean that if you've got one, you're going to get the other. But maybe it's something to do with the way the paraprotein causes blood to flow in the bloodstream. It might make it more prone to thrombosis, for example. Osteoporosis, another one. We tend to see more in patients with MGUS than non-MGUS patients. So, these things aren't causing MGUS to progress. They're just sort of, if you like, associations with MGUS.
And how much of that is to do with the population that has MGUS? Is it an age-based thing?
Yeah, I think there is a certain element of that, Alice, certainly, because, for example, osteoporosis is an obvious one, much more common in older people than younger people. So, and likewise MGUS. So you have to be careful about drawing these links, certainly not in terms of cause and effect. because just, unfortunately, older people are more prone to various conditions.
Mm. And another final question on the risk. So Helga's asked that she has MGUS with 2 paraproteins.
Oh.
Will that increase their chances of it developing into a cancer?
Answer: no, it's not. It's not common, but we do see it. Not necessarily at all, because the important factor is all those risk factors I was talking about earlier. The size of the paraprotein is much more important than how many paraproteins you've got. So, and similarly, the light chain ratio is important. That overrides the question of having 1 or 2 paraproteins.
Mm-hmm. Yeah, I think hopefully that's reassuring for you, Helga. So this is a question now from Marion, who asks, how do I cope with only having phone appointments with my hematology team? I already find them difficult to interact with, and they don't find it things are getting explained clearly enough.
Yeah, that is a problem. I think, I won't say post-COVID, because I'm not sure we are post-COVID, but I think there are more face-to-face consultations going on now, and I think you've got every right to request that. My strict rule of thumb is I quite like to alternate them, face-to-face and telephone. I mean, telephone consultation's got big advantages, particularly for younger patients who are working. They only have to come once rather than twice. Once for the blood test, then we ring them, rather than once for the blood test and then coming in again for a face-to-face. But I think there's no doubt that a lot of patients prefer the face-to-face contact, and I think you've got every reason to request, say, your next consultation is done that way. We are seeing quite a lot of face-to-face patients now in most clinics.
Yeah, I suppose there's no harm in asking and see if you can get in.
Not at all, no.
Excellent. So another question now on sort of the watch and worry, as you put it. And this patient is finding it tough to cope with the worries of having MGUS and the possible progression. But they're finding it difficult because it's not a big deal at the moment, or it's not seen as a big deal at the moment. What tips would you have to help them manage that stress?
Oh, it's difficult. I mean, we've all got different personalities, and some people are very good at putting these things to the back of their minds. Other people are less good. I think distraction is always the best thing. Keeping busy, whether you're working or not working, just have other things, because the bottom line, I know, and I'm not trying to underplay it, but MGUS is not a symptomatic condition, so it's there, but it shouldn't be stopping you doing anything. And just to reiterate, it is only the small minority of patients who do progress. So the less time thinking about it, the better. You won't be able to stop thinking about it as you approach your blood tests and your review appointment. There's nothing that can be done about that. But if you get good news at that appointment, just enjoy it and go back to doing what you were doing before.
Yeah, we tend to get quite a few calls from people as they approach their blood test, and so please do feel free to give Myeloma UK a ring if you want to chat through anything as you come up to those tests, or if you are worried, or if you feel like you've not got people to listen, because we're here to listen to you if you've got anything you want to talk about or any questions in particular. So another question, and this is looking about the future. This is from Nigel. He says, what do you think the future will look like for MGUS patients?
I'm not, for an individual patient, I don't think it's going to change very much, because we will be just monitoring them as we are now. Now, if this magic drug comes along that has no side effects but can delay progression to myeloma, then that would be fantastic. That would be, again, a marvelous thing. If that, we're not there yet by any means, because it's a bit facile in a way, because all drugs have side effects. But if we had a very benign type drug that could do that, that would be great. I think just what I would hope for all MGUS patients would be a greater awareness of the condition amongst medical healthcare professionals. I think we're getting there, certainly with primary care, we're getting there. And just to have a greater understanding of it, in terms of when a GP has a discussion with you about it, but you get the feeling the GP actually gets it, knows what it is, knows why that if you are anxious, why you might be anxious. So I think there's a great educational issue to be done, but as I say, I think we're getting that.
Yeah, and Myeloma UK is trying to help with that as well. And we've got quite a lot of resources for healthcare professionals to try and boost the awareness, particularly about living well with it as well for patients. So I think going up just to the final question, which is probably quite a quick one for you to answer, Simon. Is weight loss an important reason to contact your healthcare team?
I think so. No, unless you're on one of these great diets that we all read about in the papers all the time. No, I think if it's not deliberate, it must be a concern. Doesn't mean it's myeloma, but it might mean it's something else. So I think if it's unexplained weight loss is an important symptom, so it should trigger at the very least an initial consultation with your general practitioner.
Great, thank you very much, Simon. So that's all the time we have for questions today. Thank you for answering those. If we didn't get to your question or this brings up some more, please do get in contact with us and we'll do our best to answer those for you. So I'll just pass it back to Simon for the final part of it.
Yeah, so let's end where we started. I think it is important to have take-home messages from sessions like these. Remember, yes, pre-malignant, but the majority of cases won't progress significantly or require treatment. We've talked, both in the Q&A and on the slides, about the symptoms you should be looking out for, the importance of not being shy about telling your healthcare team if you develop them. And easy to say, sometimes not so easy to do, but try not to get too anxious about it. But look for it. If you feel you need support, do take it from, whether it's from Myeloma UK, your healthcare team, or wherever. Don't be shy about asking for support. And Alice has been good about reminding you about all the sort of help that we think we've got, both for healthcare professionals, but also most importantly from patients from the website. We've talked about the patient diary, and there's an info sheet as well, which I think will summarize a lot of what we've talked about today.
So thank you very much, Simon. I'll cover our information support services for you. Also, as I said at the start, we are here to support MGUS patients and their families and friends, as well as myeloma patients and their family and friends. And so Simon kindly mentioned our MGUS diary and our MGUS info sheet. And we will be having a new one soon on MGUS as well. If that's something that affects you, please do look out for it. But we have all of these great resources available for you. So it's online information and videos, events such as this. We've got support groups as well, a buddying service so you can talk to someone one-on-one. We have an online discussion forum, and getting that peer support, particularly around how to live well with it while you're watching or waiting, is really important. So I would encourage you to investigate that as well. And as I said, we've got our info line and our Ask the Nurse email service. So please send in any questions that you have. Give us a call if you just want to talk things through. We'll be there Monday to Friday, 9 till 5 p.m. So that is everything for today. Thank you so much to Simon for speaking to us this evening. And I'd like to thank everyone who's joined us this evening. And I hope you found it helpful and informative. If we didn't manage to answer your questions, like I said, please get in contact with us. You might go away and start thinking a bit more about this presentation, and you might get some more questions later, so do send them in. Our contact details are on the screen now. So thank you to our supporters, and thanks to them, Myeloma UK can provide free digital events just like this one for patients and their families. If you'd like to support the work of Myeloma UK, please visit myeloma.org.uk/donate. You can now rewatch this webinar on our Facebook page, and it will be available on our website soon. And so that just leaves me to say once again, thank you very much. Thank you, Simon. Thank you, everyone, for joining us. And I hope you have a good rest of your evening.